we will now switch gears, and we will now do the panel discussion. So if I could just invite all our previous speakers, so Dr. Sam Klempner, Trevor Pugh, Iris, Camilla, who will be joining virtually. I'm going to ask Teresa to come on stage. And then we have two other panelists. We have Melissa Aronson. And Melissa is a genetics counselor from the Zane Cohen Center for Digestive Diseases and senior genetics counselor. She's actually my genetics counselor as well, and she's been with My Gut Feeling for a very long time. Go ahead and take a seat wherever you guys like. And then the other speaker that we would love to invite is Dr. Jelena Lukovic. So she is a radiation oncologist and a colleague of mine at Princess Margaret Cancer Center, assistant professor at the University of Toronto. She has a passion for GI, gynecologic, and endocrine malignancies, a master's in public health from Harvard, and her primary research interests are in organ preservation. So thank you everyone for joining us on this panel. So the way that this is going to work is we're going to ask questions. I've prepared some questions, but we'll start with questions from the audience. And these questions aren't specific to any single person, and we hope that we get a perspective from both the healthcare professionals and the patients and caregivers on this panel, so it's not just one-sided answers. But just before I have some questions, I would like to open it up to the audience, please.
So the cell-free DNA test. So the technology is generalizable, but we've really only focused on hereditary cancers to start because there's a clear path to follow-up and surveillance. And surveillance is already a major part of hereditary cancer management. So there certainly are studies ongoing that are open to the entire general population. We haven't gone that route. We've really focused specifically on hereditary cancer because I actually think, and it's been such a lesson in genetics, you learn everything from the hereditary families, and then you can springboard into the general population. But I think we want a more focused, I guess, a more immediately actionable approach before we jump into trying to surveil for all cancers in everybody. So I think we'll get there, but I think hereditary cancer is actually the key to understanding all cancers, and that's why we started here.
That's an excellent question. And any other comments on screening? So either from the patient perspective or the caregiver perspective, so whether you have a genetic mutation or not have a genetic mutation, any comments on the screening process for gastric cancer?
I can make a quick comment. So Canada and the US don't have screening for stomach cancer. Places like Japan and Korea do, and that's based on the prevalence of the cancer in the population to justify screening. Like we have mammograms and colonoscopies for common cancers, but in places where stomach cancer is very common, they do have screening. And so they actually do detect cancers much earlier on average, and their outcomes tend to be better if you compare the survival, lumping everybody together in Korea or Japan against the US or Canada. It's substantially better. So I think we're still learning about who to screen in low prevalence areas. So people who spent their whole life in Japan and then have just come to Canada a year ago, maybe their risk is still more like someone who lives in Japan. And so I think we're identifying these subsets, and it's the same theme for trials. We try to pick the right patients. Same for screening. We try to pick the right patients, and hopefully we can, identify earlier cancers. I personally think there's a lot of promise to the blood-based approaches, both from a cost as well as potentially a sensitivity early detection approach. So I think Trevor's work is going to be pretty cool.
Thank you. We have more questions in the audience. Go ahead. There's a microphone beside you, just so their virtual listeners can hear.
Perfect. Okay, thank you. If there's a history of stomach cancer in a family, how do you get involved in finding out, hereditary or having testing done? Like, what would the first approach be to get that done?
It's probably for me, I guess. So generally, a referral is made to a genetic clinic, and a genetic counselor would be able to take the family history, assess to see whether family looks hereditary. So most of the known syndromes, like CDH1, which Trevor was mentioning, that causes hereditary diffuse gastric and lobular breast cancer syndrome, they have a pattern that we look for in a family. So for example, that syndrome, we look for the presence of the diffuse type stomach cancer and lobular breast cancer at young ages running through the generations. And if we see patterns like that, or in Lynch syndrome, colorectal and gastric and uterine cancer, then we offer genetic testing, which is usually a panel of genes, often 20 or more genes that are associated either directly or loosely with stomach cancer. And we test the person to see if they carry any genetic changes that would suggest they have a syndrome. And if they do, then their siblings have a 50-50 chance of having it. One of their parents has likely the syndrome. There's a 50-50 risk they could pass it down. Although I will say that in early onset gastric cancer, the majority of our patients don't have an identifiable syndrome. And so there's still a lot we have to learn about in genetics. What might be causing these early onset gastric cancers? Is it environmental risk? And then once we identify the syndrome, what kind of screening do we need? It's not usually just one cancer we're watching for, but gastric and breast cancer. And that's where Trevor's study could help us to start looking for cancers that are not easy to screen for, like gastric cancer is not.
And I just wanted to say something from the patient perspective and in terms of advocating. And first of all, I want to say, welcome, Camilla. I know you're doing double duty today, so thanks so much for joining us. You can probably speak to, I'm sure, any of these questions, but one of the things that we really, really try to bring to the forefront with the people that we support is that if there is a history in their family of multiple cancers or whatever, to actually ask for a genetic testing. Like we pretty much, anyone that comes to us as a new patient, or if a caregiver comes and asks, one of the first questions that we will ask them in a group is there a family history? If there is, and if they're younger, we always say, absolutely ask for genetic testing. I mean, our feeling is, and I know Melissa agrees that, they automatically test with, I guess, is it colorectal? There's like a baseline test that they do, but they don't do it for gastric. But yeah, I would have never known. I mean, I was tested, had no idea, but we actually, that is definitely one of the biggest pieces of advice that we give to anyone who comes new to us. Just to kind of tick that off.
I just wanted to make one more comment that Trevor showed a great picture in his slide. When you look at hereditary syndromes, meaning you inherited a genetic problem from your parents that makes you more susceptible to getting cancer in your lifetime, versus looking at the tumor samples genetics, which is what you heard about in the talks today, which can sometimes say, okay, this cancer, every cancer has genetic mutations in it. So what mutations are in this cancer? Does it have features of this MSI, which may indicate immunotherapy is helpful, or what other features? So looking at a tumor and seeing what mutations are in a tumor may not be the same as doing a blood test for hereditary syndromes. And so it's good to maybe think about that when you're speaking to your oncologist or physician.
And then just one more comment. So it sounds like a lot of research is happening and new genes are being discovered, yearly. So I guess for those that may have been diagnosed and are long-term survivors, what would you advise in terms of retesting on genetics level?
So in 2021, Ontario revamped our panel of testing. So we used to test one gene here, one gene there, and now we do a panel of genes. So we always encourage survivors or their caregivers to get back in touch with genetics every few years to see what is new as far as updated gene testing, because we're still constantly learning about genetics and new genes that can cause hereditary syndromes.
Yeah, I would totally echo that. It's amazing how fast the science and research and understanding of the genetic causes of cancer are, and the scale of testing. It wasn't long ago we were just test 1 or 2 genes at a time. Now they're gene panels, some of them are multi-hundred. And I think both on sort of in the genetic world, what I'd love to see is every cancer patient gets some sort of germline test just to rule it out right at the front. Because I think trying to pick and choose certain cancer types to get a genetic test, it's operationally very complex and people are missing out. And the nice approach with the whole genome approach is you can computationally update knowledge over time rather than having to go back and do a second test. So the technology is moving very quickly, and I think building research in as part of care is the best predictor of outcome. Participating in research really gets you access to great technologies, and those technologies that are researched today, the goal is to put them into the clinic tomorrow. So it's really important to participate in those types of studies early on because it's going to build that future state, which to me should be, if you're a cancer patient, you should get a genetic test, and at some point that test should be a whole genome.
You have it removed, if you have the tumor removed, have they collected that profile information to know what type of marker it is? So that if down the road you want to do genetics, they can find out what type you had.
It's extremely heterogeneous. It depends where that work was done. Were you part of a research study? Was that sample banked in a research lab where a researcher could go back and access that material? So it's very hard to have one answer to that question because it's very different, depending on the cancer type and what's done with it. I'm most enthusiastic about the holistic approaches where you would bank all tumors, and that would be a bank that then researchers can go in and learn more about every single cancer. So consenting to biobanking is another very important way that you can contribute to research because these go into databases where we can look at that tissue in the future to understand how they work.
Thank you.
There's more questions in the audience. Go ahead, sir. And if you could use, if you could use the mic as well. And I see there's somebody at the mic. Okay. Can we get him a mic? Or I can repeat the question. Go ahead. Yes.
I'm wondering if artificial intelligence will play a role in predicting your analysis in that, being able to bring things together from all over the world and be more predictive of what your research.
Yeah, it already has. So that chart I showed of all the different types of data, it's all about machine learning and data integration. Our number one barrier is data access. It's actually very difficult. We can sequence the entire genome. It's super hard to get access to like your medical history. Like we really need patients to be a partner in that, to consent to sharing not just of the tissues, but what treatments did you go through, which treatments worked, which ones didn't. It gets very complicated when you get into clinical trials, but these technologies are amazing and we're very good at making data. The hard part is putting it all together and assembling sort of that complexity of data and having access to not just the DNA, but probably more valuable is all the clinical data that come along with it.
Go ahead, Felicia.
Thanks very much. So I'm Felicia Flowett with AstraZeneca. Really pleased to be here, and thanks very much for having us and for all of your great questions. So I know we'll get to this more this afternoon. Burden of surgery is a big deal for patients. And one of the things I didn't understand from your talk, Dr. Klempner, is do any of these new therapies have the potential to help reduce the burden of surgery or improve outcomes after surgery? Like, are you looking at anything neoadjuvant or therapies that make, surgery recovery easier for patients?
Yeah, it's a big question. First of all, Iris, you're an impressive person. That was a really good talk. Yeah, so the stage 4 setting is like the testing ground for most new drugs. And it's for two reasons. And one of them is that this is a patient population that doesn't have options that are known to improve survival. So there's limited toolkit. So it's a great place to introduce new tools. The sad second reason, which is the reality, is that if you want to see the effect of a new drug, you need some way to assess that. Usually it's a scan, and sadly in the late stage setting, these events happen more frequently. So you get information about your drug faster. So almost all oncology drugs are initially developed in stage 4. And then the very logical question is, if it works for a stage 4 patient, can it work for a stage 3 patient or a stage 2 patient? And that's actually not been as easy to answer as you might think. There are some successes for sure. MSI high patients, which is a subgroup who are very responsive to immune therapy, that has been a great success. We now take the learnings from stage 4 and apply it to stage 2 and 3 routinely. And it can, I think, in some situations, spare patients surgery potentially who have dramatic responses. This is still an emerging area, but definitely an area where we will look and we will have discussions with patients about potentially even avoiding an operation in this defined group of patients. But that only covers like 10% of the population. So the big ongoing question is, can we move these other targets like immune therapy and HER2 and FGFR2 and Claudin into the stage 2 and 3 setting? And it's a big investment from everybody. It's a big investment from the pharmaceutical companies because these are big trials that cost a lot of money and require years to get an answer to. It's a big investment from patients because you're all the ones going through the therapies and the surgery is a huge operation. And then, of course, it's work for everyone on your care team, documenting, charting, et cetera, et cetera. And so the answer is yes. It's exactly the way to go. And I think, in a few years from now, if on the 10th annual My Gut Feeling Symposium, I probably will have some better answer to that question where we will have some more drugs that have moved into the non-metastatic setting. We want to be in the business of curing more people, not treating more people. And so to do that, we need to get these drugs earlier on.
And just a follow-up question, at your center, what do you guys do when patients that are initially unresectable or stage 4 go on to immunotherapy or other treatments and then have a fantastic response on imaging where they're disease-free on radiology? And maybe Dr. Lukovic can also comment on that as well.
I send them to Lorenzo. No. No, first of all, we're very happy when that happens for patients. It's unfortunately a small group of people that have what's called a complete response, where what you could measure before is now gone. I think before we send someone for a big, potentially curative or at least curative intent operation or ablative therapies, we want to be as confident as we can that we're just not suppressing the tumor below the level we can see and there's still a lot of disease. Or are this really the person where we killed the majority of the tumor with the therapy? Teasing that apart is actually not so straightforward. It's exactly where areas like Dr. Pugh's work in cell-free DNA can sometimes help complement. So we have a scan that says there's no cancer. Then we ask the same question in the blood, is there no cancer detectable? And actually for some case-by-case patients where they had maybe one spot or 2 spots that the surgeons or the radiation oncologists could address, we will actually think about surgery or radiation as a consolidation after a really great response. And I think we all have stories of patients who've done exceptionally well. And so we know that there is people that helps, but we also are not that great at deciding who they are. So it's a very risk-benefit discussion with all the patients because you're basically asking someone to go into a gray area where we have very little data with the hope on the back end that they'll be alive many years longer, but knowing that they're potentially going to pay a big upfront price, which might be an operation.
So the other thing I wanted to add, so I'm a radiation oncologist, and part of the question that was just asked was with respect to moving therapies up front to make surgery more effective or the surgical recovery better for the patients. So there is a trial called Top Gear that's evaluating the use of preoperative radiation therapy in combination with chemotherapy. It completed accrual 2 years ago now, and the results are expected to be presented next year. So hopefully that's something we'll be able to share here at next year's conference. The primary endpoint is overall survival. So we are looking to see if patients are living longer with us. And then in terms of Dr. Klempner's point, for sure, sometimes if we see these really, really great dramatic responses everywhere but one tiny area, we do consider high dose precise radiation called SBRT, or stereotactic body radiation therapy. It's non-invasive, sometimes better tolerated than, oftentimes I will say better tolerated than surgery.
Thank you. I think there's more questions in the audience. Go ahead and please use the mic if you can.
My voice is still shaky from listening to Iris, so. My husband has Lynch, MSH2, and he's had a full stomach removal. That being said, obviously, we're concerned about other things and the progression of what have you. In regards to people with Lynch syndrome, does treatment differ? I understand that you're looking at ways to find things early, but do people with Lynch respond differently to different treatments versus people that are non-Lynch?
Yeah, the answer is yes. That is it's the biology of those cancers is a little bit different than the biology of non-MSI high cancers. And so I think that the trends that we've learned is that Lynch or other MSI cancers tend to be maybe a little less responsive to chemotherapy, but more responsive to immune-based therapies. I think that is most of what we can say in terms of whether they respond to other targeted therapies. If the Lynch cancer also happens to have another mutation in one of the other targets, we don't really know the answer. In colon cancer, there's some data where people who have MSI high cancers commonly also have a BRAF mutation. It's just another gene. And we have drugs that can hit that mutation. And patients with MSI high cancers and a BRAF mutation, or MSS cancers and a BRAF mutation, they actually both respond to the targeted therapy. So I'd say the things I can say with some confidence is less response to chemo, more response to immune therapy, which we reach for immune therapy for Lynch or other MSI cancers as sort of our first tool because we know that it's particularly active in that population. There's a lot of really kind of sciencey nuances to it, like if the mutation is shared between all the cells, like what's called a clonal neoantigen burden, for example, versus something that only exists in some clones, those tumors may have different sensitivity, but this is really not in the clinic yet. It's more like how we're studying it in mice.
Yeah, I would just say MSH, so in Lynch syndrome, which is a hereditary condition, the cause of Lynch syndrome is you have a mutation in what we call your mismatch repair genes. And the goal of these genes is to go through your genome and fix mistakes. And so when it doesn't work, the mutation, there's a high burden of mutation in the tumors, and it makes it look a little different to the immune system. That's also called microsatellite instability, or MSI high. So because these genes aren't working properly, there's a lot of instability in our genome. And the thinking is that your immune system recognizes those cells as foreign, where for most people who develop cancer, their immune system doesn't recognize the cell as foreign because it's very good at masking itself. And so since chemotherapy will hurt white blood cells, which is your immune response, the thinking is maybe give it immunotherapy to boost up your immune system to fight it better. And there's a lot of research that not just with Lynch tumors, which are almost always MSI high, but even if it's sporadically MSI high, they respond better to immunotherapy. But almost every Lynch patient will have an MSI high tumor, and only about 10 to 15% of sporadic cancers will be MSI high. But those seem to be the patients that may respond well to immunotherapy. So yes, it appears there might be some advantages to having Lynch syndrome cancers as far as that goes.
I'd also just comment for the cell-free DNA test, the fact that these tumors have more mutations is actually one hypothesis we want to test in this study, because in theory, since they have many more mutations, they should be easier to identify circulating in blood as well. So we don't know yet, but one hypothesis is high mutation rate cancers may be more easy to detect in the blood test. So that's one of the questions we want to answer.
And if I can just sort of speak from my own personal experience, because I have MSH2, and when I was diagnosed with my third cancer, which was cancer of the ureter. So I had the surgery first, and they removed my right ureter and kidney. And then I went through the protocol of chemo, which was not fun at all. But I went through the full protocol, and 3 months later, I was diagnosed with a tumor in my bladder. And so I honestly don't think the chemo did anything. That was sort of like my own personal, I'm no doctor, but, after like all that poison in my system, there was still stuff floating around, and I am definitely MSI high. So it didn't work for me. Not that time anyway. It did work when I had my gastric cancer because it kind of put it at bay for 9 years. But that time around, I don't know if it actually gave it a bit of a pump, to be honest with you.
There was a question in the back. Ramin, would you mind coming to the mic?
Planted him.
Sorry, I'm almost afraid to ask the question because I nowhere qualify as the group there, but I have to ask this, and I may be wrong. I understand the details of research that involves both genetics with stomach cancer and all the great work that you're doing, but I've been trying to find this out to address this just from a structural top-down approach. Correct me if I'm wrong. I know we can't find data sets because we don't have data, but how come there are no any types of studies of risk assessment done when it comes to cancers that they have some genetic combination with stomach cancer, and some actually don't, but they still don't have a risk assessment or a guideline for germline testing, at least because they don't fit into that, because those are the areas that I found out. It's basically about the first step before we even have the answer. To make it simple, maybe I'm wrong. There is no, how come there is no proper triage? Even for somebody who has Lynch, there's no hospital distinguishes that from a stomach cancer or some other cancer, a cancer with Lynch who has the higher rate of occurrence and at more risk. But this is not just about Lynch. I've always thought why there are no risk assessment done, because you can still do that to create some forms of guidelines before we have the data. And this is not that actually is never expected from doctors. It's more like public health or the administrators. That's just my question.
So I think the question is kind of about nature and nurture of the stomach cancer. So risk factors for stomach cancer and how maybe patients that are susceptible to a genetic mutation can maybe mitigate their risk factors.
This is basically a risk assessment study. Like I'm a numbers guy, so I can understand that. But if I had to look at that problem, I would classify, let's do a risk assessment, and everybody would be part of it. But it's not as simple as just, if it doesn't fit this, we have to do, I know those details are there, but there could be at least, I don't know, we can break it down to 3 different areas because we don't have the answer, but we should have a risk assessment done. There is like no, it's gonna sound strange because I personally can't think of like just saying that because we don't have data and stuff, we can't do it, but we can still, why do you think there is no such a thing, an approach? I've actually looked into it, and with my wife, with Lynch, it became more like I'm trying to explain this until it was finally bought into. But of course, again, it's not the doctors. I'm not criticizing. It's the administration. I don't know who it is that funds different things. That would be so great from a patient's end. If there was a risk assessment, a proper statistical, based on what we have, risk assessment. It doesn't have to be exact. And one cannot just deny it and get out of it by just saying, because we don't know the details. We can do an order of magnitude risk assessment. I mean, those are the only areas I know. But why do you think, first of all, if there is such a thing, and why do you think there is?
Yeah, I think part of what you might be commenting on is the siloing of research and clinical care and data across disease sites. And I think the key to break out and build models like you've described is to really have systematic testing across all of cancer. Right now it's very site specific, it's stomach or something else. So raise it up to be one platform that everyone is comparable on, because right now you're not.
Right. It's
And then
basically
to
like
collect
looking at the
clinical data.
forest, which is like, I kind of think that should be an obvious thing. I understand the trees, and that would be the first thing I would do to solve the problem, just to kind of from the patient's end. And this is not about doctors or surgeons. You guys are doing the best that you can, and you shouldn't be actually in charge of any of that. But I'm asking, why is it not even considered? Is this something that we have to advocate for to get the public health people and to actually bring in a very simple logic that people have used over thousands of years? When they have water irrigation problems, when they have Ebola, you can't just go say we don't have the answer. Risk assessment gives you the triage. At least you put some cushion on the treatment of or screening.
Yes, so
it's
that's what that's part of the advocacy work that we do. And I worked with Melissa on a white paper about just trying to put together guidelines to push it forward. There's no, it's trying to get funding, it's trying to get the approval for it. It's not that the data is there, it's just how do you find the resources and the funds to pull it all together?
There is no funding, but it's all, to me, almost sounds like a very simple, logical question.
Okay, but you still need, need resources.
Like nobody, because it applies to the forest, I think, I can't ask anybody from the panelists just because it's about the administration of public health. It's not even political. It's basically, a category in doing triage, as simple as that.
So I think I think what I'm getting from your question, I think it's a really good question, is that we need to select patients who might be at an increased risk of gastric cancer and offer those patients screening, but maybe not every single person or every single Canadian needs gastric cancer screening. And it's, do we offer it to a certain subset of patients with certain risk factors? And I don't think we've fully defined that yet. But that is definitely something to advocate
just
for.
As a policy,
and-
like
and
right now,
to look
at this
into,
time,
yeah.
if I go to an emergency or any hospital in North America because of some form of cancer, and also just utter the fact that I have Lynch syndrome, let's use any syndrome or genetic, they consider it, doctors consider it, but there is the administrators, the system doesn't give that a higher risk assessment, where you could still do a very simple breakdown of risk assessment with everything that we have so far to actually say that. So you're not doing injustice to some, it's not about democratizing who's getting cancer, who's better and worse. It's basically a risk assessment, just like how you did it, the public health finally got it with COVID. There was categorization of that. And there is also that has to do with cancer, right? So I'm just wondering why.
Raman, I think you bring up an excellent point. We really need to advocate and educate general practitioners as well as the healthcare team to assess these risk factors. But I think the point is we're just not there. But I think conferences like these and an organization, this is something that we could put to the forefront of our agenda. And I know, Jemica, you were mentioning there's a lot of online questions, so maybe we can continue the discussion offline.
Katie, can I just make one comment?
Yeah.
Just for example, with the MSI and the immunotherapy trial. So based on that information, now there are pathology departments that automatically look at MSI when they look at gastric tumors, esophageal tumors, ureter tumors, colon, endometrial, and so forth. That's a change in the system from where it was before, and that's because we want to know right off the bat, is this a tumor that has MSI? Because maybe that will change treatment. And like Trevor was saying, there's now also mainstream testing. Oncologists are sometimes ordering genetic testing if they see someone young with gastric cancer right off the bat before they even come to genetics. And that's a change in the system. So we are learning about early risk assessment based on a lot of the research that we're doing and changing things. But I take Katie's point that if you go to an emergency room and say you have Lynch syndrome, a lot of people don't even know what that means. They might not know all the cancers involved, and we may not be able to screen for a lot of the cancers that they're at risk for very easily. So there's a lot that still has to be done as far as screening, maybe through blood work, education, but where we can make improvements, there's been some movement I've seen at least.
Yeah, there definitely has, just in terms of, like, I know the work that we've worked on with certain research projects, but yeah, nobody knows about a lot of these things. And, you know, my biggest thing is, and you've told me this, just specifically with Lynch, and I don't want to get into it, but I have yet to find a Lynch specialist in Canada. One. Dana-Farber, I believe, has an entire center that is a Lynch-specific center. And we're here trying to, and this goes for even like CDH1, all the other ones, where you're trying to manage your entire, I don't know, crazy calendar. Whereas Dana-Farber has this incredible center. Like, you know, I'm sending an email next week because I do want to understand. It's just so different than here. And I think I ask Melissa every year, is there a Lynch specialist that we can go to, that someone can be referred to? And she's, no. And I'm like, in the entire country? No. And so it's quite a struggle that way. But in terms of like that, what the other thing that Melissa mentioned, which is, you know, the automatic testing, that is like so different than when even 10 years ago.
I'll also say that, to bring it back to hereditary gastric cancer, which is a little more isolated. So at our hospital, we have Sav Brar, who does the screening, and Carol Swallow, who does the surgery. And we've made ourselves a specialty clinic because we want people to have a place to go where there's experts at screening and doing surgery, like prophylactic gastrectomies, for people at risk. So there's no funding from the government that says you have to be a specialty clinic, do this, but we made it our mission to do that at our hospital, and there needs to be a bit more of that for other syndromes.
So there was a couple of questions online, but Iris also had a question, so maybe Iris first.
My question is for Dr. Klempner. First of all, thank you so much for your research that you do. You do buy families more time, and that's great. I am wondering, I know you mentioned one of the prognosis is having ascites and obviously the burden of disease. Are there any trials coming up or anything that patients should be on the lookout for with respect to conversion therapy, where they take someone who may not be doing so hot right at the beginning, but potentially turning them into a surgical candidate through chemo, systemic, intraperitoneal chemo? What hope is there on the horizon for the patients that may not benefit just from chemotherapy alone?
Yeah, it's a big question.
Sorry.
No pressure. So yeah, that's actually what they do call it in like Japan. They call it conversion, and they do the same thing in Korea, where they take people with kind of moving targets in terms of how you define someone who can go from like 2 spots in the liver and 1 spot in the peritoneum and the stomach and make them into a surgical candidate. So one important thing that we haven't done a great job of, and maybe some of the surgeons can correct me, is really defining the criteria. So like, what is too much cancer to be realistic chance of removal, and what is a reasonable chance of enough cancer where we might be able to, if we have a good response to our therapy, get it out. Right now we don't have great criteria for that. The peritoneum is really kind of the bane of everybody's existence with gastric cancer. It's probably the cause of grinding, horrible symptoms that really never stop. You know, your gut doesn't work very normally. You have to go in for drains. You take off a lot of protein with the drain. People lose a lot of weight and muscle. And I'm not teaching you anything you don't know, I'm sure. It's remarkable how little we actually know about the peritoneum. Like, are the tumor cells and the immune cells that live in the floating environment the same as the tumor and immune cells that live attached in a liver or in the stomach? And we don't really know the answer to that very well. At least if you sequence the DNA, they look kind of similar, but clearly they behave very differently. So there's things beyond the DNA, like sort of the wiring and the programs that operate in the cells and the immune cells. And so that's one area that there needs to be a lot more research in, is like disentangling the peritoneum so that we can pick, because the things that people have tried are not really based on a specific biology. So we say, okay, chemo works in the vein. What if we just put chemo in the belly? Well, it hasn't worked out that great. Especially when you're putting the same chemo that someone may have gotten in the vein 6 months ago that didn't work, and then you're putting it in the belly and you're asking it to work. And that's probably not realistic. So really need to understand and pick. There are some really cool stuff that I'm excited about that's like pretty early on, like can you take, let's say, Claudin 18.2, and can you put the Claudin reprogrammed immune cells like CAR T cells actually like right into the abdomen? And in the US at the NCI, they do this for like ovarian and pancreas cancers. They have, the protein is called MUC15 or something like that. It's another surface protein, and they build an immune therapy specific against that, and they put it in the belly. And maybe it will work for some patients. I think short answer to your question is I don't know the answer. The long answer is it's certainly an area that we need to look at very, very closely, because if you take anyone with stomach cancer and follow them through their whole journey, it's about 40%, maybe even more, will get peritoneal disease at some point. And it's usually not a good thing.
And I see Dr. Caroline Swallow and Dr. Sav Brar, both surgical oncologists at the University Health Network. They both had a comment. Is there anything you'd like to add, Dr. Swallow?
Yeah, just to Iris's question specifically, wanted to talk about the role of surgery in stage 4 gastric cancer, which is highly controversial. And I think we went through a time period where surgeons were doing gastrectomies in the setting of stage 4. And after the Regatta trial showed that it wasn't beneficial, that was a Japanese trial, we sort of educated people to stop doing that. But now, with all of the new therapies, with immune therapy, with targeted therapies, with HER2, and with more testing of patients to be able to give them precise therapy for their stage 4 disease, I think we're getting to a point where we need to open this up again, this discussion, and reconsider. And we do see people, for second opinions on a sort of case-by-case basis to consider metastatectomy, particularly liver mets, in somebody who seems to have good biology. And also, I think HIPEC for gastric cancer is going to be coming to Ontario. It's going to be funded in some peritoneal malignancy sites. And it's obviously got to be for people who are highly selected, as you were just saying. But I think we as surgeons, we got the message out there so effectively that you shouldn't operate on people with stage 4 gastric cancer, that now we're seeing almost a resistance to even think about it. So I think we have a lot of work to do as a community to kind of step back from that attitude and consider each patient as an individual.
And Dr. Brar, did you have... Yes. Don't run.
And I would never disagree with Carol ever about anything. But I do think the more we've learned about the role of the immune system in gastric cancer specifically, I think also should make us pause about which patients we do decide to do this. You have chemotherapy that's done great, immunotherapy that's done great to make the tumor go away. You then interrupt that therapy with surgery, but also maybe blunt the immune system. And we know in animal studies that if you do a laparotomy in a breast cancer mouse model, which is a big incision in the abdomen, those mice do worse than the ones that you don't. So as a surgeon, I'd love to cure all gastric cancer with surgery, but we do need to be careful. And there is, to Dr. Kempner's point, there is some data that these metastatic sites are different. So in the original FLOT study, there was a side study that showed, maybe the lymph node metastatic patients did the best, and that makes sense, I think, to a lot of degrees of what disease sites have access to the chemotherapy. The liver did a little bit worse than that, but the worst was peritoneum. And I think thinking of stage 4, like we think of the primary cancer as one disease, thinking of the stage 4 sites differently is also something that's needed. And I think these patients, as Carol said, need to be considered, and we have to discuss them in multidisciplinary groups like we do have at UHN and Mount Sinai, where, all the key members of the team discuss these patients and look at all the options.
Thank you. I think that's a very hopeful discussion, and that a lot of things are coming down the pipeline, both from the systemic therapy perspective, from the surgical perspective. But I think the point here is, we need more study on healthy patients to really learn which patients would benefit from surgery and which patients would benefit from certain systemic therapies. Now, we have a lot of questions online, and I do apologize. We are running late on time, as always. So let's, Jemica, maybe read out a couple of questions online if she can.
So this is a question for the doctors, and this is from Harvey online, and he's just asking, is there ongoing research into the relationship between PPI drugs and gastric cancer?
I think that some countries have like really amazing national health systems, and so they get these awesome registries in like Sweden where they can capture like the whole population, and they pull out trends that they see, like X medicine is associated with risk of Y. And some of those studies have, suggested various associations. I'm honestly not aware of a lot of specific work. I'm sure there is, it's just not my area. Looking at PPI usage and cancer risk. There's been many older trials of taking people who had gastritis or ulcers and giving them PPIs and looking at the subsequent risk of cancer, or even treating H. pylori. And some of those suggest there are people who we may be helping to prevent by treating the risk, reducing the risk by treating the pre-cancerous problem, whether it's something to do with chronic inflammation. But I don't really know if there's big trials that are asking this question.
Any other questions from online?
And then Emily was just asking, because I know this was briefly mentioned, I believe, in one of the presentations, but just in terms of prevalence, what is the prevalence of stomach cancer among the South Asian community? So Indian, Nepalese populations.
I don't know that specific region of the world, but it does raise a good point that there's extreme variability. So in the US, stomach cancer is around 4 cases of stomach cancer for around every 100,000 people. And in Korea and Japan, it's like 38 or 40. So like 10 times the population incidence of the cancer. I believe that regions you're describing are somewhere lower than that, but higher than the US. But I don't know if it's 12 or 17 or whatever.
I think it's Natalie. Sorry, I think Natalie Coburn has actually done some research this in Canada. So if you're from South Asian countries and you immigrate here, your risk is lower than the baseline risk of Canada. And it brings up an important point. The speaker from California, Camilla, brought up that she was from a high-risk ethnicity, had symptoms, and wasn't investigated. When you talk to the people in Japan, they say that the early gastric cancers aren't always from screening. It's from people knowing that these symptoms are associated with gastric cancer and getting a scope very quickly. So 2/3 of their early gastric cancers are not screened, they're investigated quickly. And he says, you can go into any strip mall and get a scope right away. So if you're from South Korea and Japan, your countries are famous for having gastric cancer, but half of all gastric cancers in the world are from China. There's other parts of the world that are very high risk, including Mongolia, Central Asia, like Iran and other countries in that area, Eastern Europe, and the parts of South America near the Andes Mountains, so Chile and Colombia. And there's some countries like India, Pakistan, where the risk is lower than even the West. So if you're a caregiver out there, or even a patient or a healthcare worker, especially if you have patients from these areas and they have symptoms, is to not brush them off, because they're being born there and immigrated to Canada, the risk is probably higher than the baseline Canadian risk.
Thank you. So again, just being mindful of time, I think I'll ask one more question just of the group. So this is a question for the patient survivors and caregivers on the panel. If you can give one piece of advice to your healthcare team, what advice would you give from either the patient or the caregiver perspective? What one pearl can they take away from today?
Oh man, I have so much. I think it's just trying to understand what the patient wants. Even if your outcomes aren't good, even if it's not going to make a shiny trial, at the end of the day, it's somebody's life. So try your best to give them at least what they want, because at least in our case, if the outcome is going to be death anyways, then you might as well try your best. From my perspective, I just love someone who wants to try to help. And I know we had insane requests of Dr. Alamova, and she pretty much did them all. And for that, I will be grateful for the rest of my life, just because she listened. And I know Katie's on her team too. And Yvonne, the researcher, is there as well. I think it's just listening to your patient. If they want to go through with a risky surgery and they want to try it, especially if the patient is young and they have a family, I think it would just be to try your best, because not everybody's a statistic. That's the only advice I can give.
Yeah, and absolutely, just to build on exactly what Iris said, it's definitely to my healthcare team, and I've had a great one, but actually to listen to what the patient is saying. The patient knows their body way more than you do. It's just the way it is. And just to actually make patients very much a part of the team. So not talking at them, but talking with them, talking with their family. It has to be a holistic, it has to be a real team, because you are dealing with people, especially with gastric cancer. It is lethal, we know that. Even in the best of circumstances, it's one of the most complex of the cancers. And so the more a patient is part of their care, I think the better the outcome is overall.
Thank you so much. And with that, I'd like to thank all our panelists today. So Dr. Klempner, Dr. Pugh, Dr. Lukovic, Melissa Aronson, Iris, Camilla, and Teresa. Thank you so much. I see some hungry faces. So we'll start lunch, and we'll let you know when we're ready to go, but maybe half an hour to 45 minutes to let you network and mingle as well. Thank you.